is much easier if we're already using our guts. I want to talk very quickly about the differences between feeding and swallowing, because they are two different things, and then I really want to spend most of the time talking to you guys about what you've encountered, how feeding and swallowing is going with your kids, what you found helpful, and what, if there's anything, any barriers you've hit, if we can kind of talk through some ideas for maybe working on that. So feeding is like a really holistic gestalt, right? It is the process of cooking food together. It's the process of setting the table, sitting down together, putting your kid in the high chair, putting on the bib, or sitting in the chair, cleaning up afterwards. The sensory, right? The smell, the sight, the whole experience of the meal, that's feeding, right? And swallowing is just a small piece of that. Swallowing is the physiological act of taking food into the mouth, being able to process it properly and get it down into the gut. And so we usually divide that into 4 stages: preparatory, which is where we're chewing and trying to move food around in our mouth, the oral transit phase, moving food through the mouth, swallowing, protecting the airway through the throat, and then into the esophagus. So that's the difference between feeding and swallowing. And I like to think of oral feeding as something that's supported by multiple systems. And you have to start with the big picture, which is the whole patient, right? The physiological stability, medical stability. If any of our medical systems that are involved are out of whack, then we're going to have some issues. I'm going to tag through all of these guys here. So while we're thinking like oral motor, oral sensory, and swallowing, that's feeding, right? No, feeding is bigger than that. Feeding is supported by a whole body and wellness, right? So we have to have medical stability. When your child is in the hospital, they're not stable necessarily, right? We've got something out of whack that doctors are trying to work on to make better, make more stable, make progress. So if we're having respiratory distress, I am breathing really fast and working hard to breathe, then eating is not at the top of my agenda. If I'm having, severe constipation, if my gut isn't working right and I'm having any sort of gastric issues and I'm in the hospital for that, this is not the time to really advance feeding skills, right? We need that system moving well. And what we notice is that when kids don't feel good, they don't want to eat, right? Do you ever have any of your children when they're in, they have a tummy bug or when they have a cold, what happens? Do they eat more or do they eat less? They're eating less, right? So it tends not to be the time when we're going to be pushing forward skills. So we want to have medical and physiological stability first, and that's working closely with your medical professionals and therapists to make sure we have all our ducks in a row. We're breathing as comfortably as we can. Our tummies are working as well as they can, like yesterday with our motility expert talking about all of the ways that we're working on helping the gut to move food, right? If food is moving through, I'm going to be hungry and I'm going to be willing to eat. If food is not moving through, I'm not going to want to eat. Cardiovascular. So a lot of children with cardiopulmonary issues poop out very quickly, they lose energy very quickly, even just breathing can be very taxing for them. And chewing and eating, especially in our younger children and in infancy, it's one of the hardest things we ask kids to do, especially in infancy, right? They sleep, they poop, they eat, and they eat. And eating is the hardest thing that we're asking them to do. They have to coordinate breathing and swallowing at the same time. There's energy expenditure. So children with cardiopulmonary disease very often have difficulty either meeting their nutritional needs or being interested in eating at all, right? So if that's all in place, then we can start talking about the developmental stuff, right? Developmental stuff. So children come out and they follow this progression of motor development. And we see it's a very common or a very well-studied progression for all children, for all of us in our brains. Because we start off in the womb, we're all nice and curled up inside, we've got boundaries, it's warm, all the sounds that come in are nice and muted, so all of the sensory input coming through the room is actually quite nice and buffered. And then we come out into the world and suddenly we don't have those boundaries anymore, and it's cold, and there are people being really loud and there are bright lights, and the brain has to learn how to synthesize all of this and learn how to move my arms without those boundaries and how to hold my head up and how to support my trunk. So this motor progression is a very common sequence that we see. And what we also notice is that feeding follows that progression well. So notice the infant here is totally dependent dependent on his father to hold and support his head and hold and support his trunk so that he can focus on the oral movements of sucking on the bottle, the very rudimentary movements of the tongue, just forward and backwards, right? But then as kids start to get more head support, now all of a sudden we're talking about we can hold our bottle by ourselves. We don't need our parents to hold the bottle for us. And then as the trunk support comes into play, we can move to sippy cups and to open cups. And this allows for more sophisticated oral motor movement, right? And same thing with feeding too. We go from this puree, very easy. I don't have to chew it. I can just move it back in my mouth like I do when I'm swallowing milk from a bottle, to a lumpy puree. Ooh, I can't swallow that right away. Sets off that gag reflex, the oral sensory piece, right? Oral sensory is our protective mechanism to make sure that we're not swallowing something that's not ready to be swallowed. And so what do we see when you give babies chunky puree for the first time? Right? That gag reflex scares the pants off of everybody the first time it happens. Oh my God, they're choking. No, they're just gagging. It's okay. But the lumpy puree, right? So now they're like, oh, I have to do something slightly different with my tongue. I have to mash it against the roof of my mouth before I can swallow that lumpy puree, right? Process it a little more. And then we move on to chewable foods and learning about lateralizing our tongue from side to side. Being able to do that refined movement requires us to have trunk support and head support. So if we don't have trunk control, we don't have head control, doing more refined oral motor movements for eating can be really hard. So when we have children, let me just bounce ahead a little bit. When we have children who are having issues with trunk stability and head stability, if we have prude belly and we don't have good trunk support, we need to artificially create that, right? I'd like us all, and this is in my practice in general, I don't think about age ranges. I think about skill level. So, for example, if I have a child who is 12 months of age, but they don't have trunk or head support, I'm not going to be progressing that child onto solid foods until I can get them well supported in their trunk and in their head. If I have a baby who's 4 months of age and has fantastic sitting skills and is already kind of sitting semi-supported, this is a baby that we could start purees on early, even though the APA is saying for 6 to 8 months, right? So that's a child who we can think about starting earlier, because we're matching up their motor development with their feeding skills. So what are some of the signs that kids are having trouble with swallowing or feeding? Some of these might sound familiar to you. Gurgly voice after eating, anybody? Coughing, choking during eating? Yep, okay. I heard that one come up yesterday. How about taking a really long time to eat? Yeah. Yep. Maybe difficulty chewing foods appropriate for their age. Good, okay. And refusal behaviors. Tough stuff at meals. Yeah, okay, yeah. What kinds of things are you seeing?
The mouth pocketing.
Mouth pocketing, the pocketing, good, okay.
Pocketing and only eating Cheerios and
Puffs and Cheerios.
Puffs and Cheerios, okay. We like those crunchy dissolvable solids, yeah. Okay.
Nothing slimy, nothing texturized.
Okay,
just
great. So
dry.
very
Dry.
limited.
Dry.
Yes, okay, good. Does not like wet things. I hear this one a lot, don't worry. So yeah, limiting yourself to specific food groups, specific textures. Sometimes I have kids who only eat white food. Doesn't matter what the texture is, it just can be white, no colors. Or only orange foods, or only red foods. They seem to like red foods a lot. So that might be a sign of swallowing or a feeding difficulty, and more classic kind of feeding difficulties outside of a swallowing problem. Maybe difficulty transitioning from the bottle onto a new drinking device, like going to a sippy cup kind of situation. Avoiding or restricting one's food intake, so really only focusing on those limited food groups, and the disruptive behavior at meal times. How many of your kids have had swallow studies? Oral pharyngeal or esophageal or both? Both? Yeah, okay, good. When we're trying to figure out if a child has a feeding and or swallowing problem, it's actually really important for us to rule out dysphagia, or rather aspiration most importantly. So dysphagia is a problem with swallowing, the muscles that we were talking about before, And it is more than things going down the wrong pipe. Aspiration is food going down, food or liquid going down the wrong pipe. Dysphagia is any difficulty with the mouth and throat, so weakness, discoordination, as well as aspiration. Aspiration is the scary one and the one we want to really keep an eye on, because we do not want hospitalizations on children who already go to the hospital a lot, right? Don't want pneumonia, don't want bronchiolitis, don't want choking events. We want to avoid those. So it's really important for us to make sure that aspiration isn't happening before we start moving on with anything else. So what causes feeding and swallowing problems is probably looks pretty familiar to all of you. Pulmonary disease, GI disease, developmental delay, medication side effects. So there are certain medications that make children really sleepy. There are certain medications that make them not very hungry, make them feel nauseous, give them GI side effects. And there are certain medications that make them voraciously hungry, which can also be actually not such a great thing when you're trying to get a child to learn how to chew. Cerebral palsy and brain injury. So I know in our active 2 population, we have a lot of risks of recurrent strokes. And depending on where that stroke is, that can have a real significant impact on the ability to feed oneself, as well as the ability to swallow safely. So feeding and swallowing is something we do have to keep a close eye on, especially in a dynamic and changing picture. Whether it's hospitalization versus home, or an evolving disease where we have stroke after stroke after stroke, right? So it's something that we're going to want to keep a close eye on. So I want to return to this picture for a moment. We talked about oral motor, how our tongue moves, how our throat moves, how we coordinate all those things. Oral sensory, so our response to stimuli, hypersensitive versus hyposensitive. So do we have a child who is really sensitive to texture and will gag the second there's a tiny little lump in their smooth puree? Or are we hyposensitive and kids stuffs their mouth full of food just to get enough sensory input to realize there's food in their mouth and to chew? And you can give them like Frank's hot sauce and they don't even blink at it, you know, really alerting flavors they don't really seem to pay attention to at all. And maybe actually you notice, oh wow, look, they're actually chewing for once they have a really spicy flavor in their mouth, because now they can finally sense it, right? But we also have something with sensory that we need to be very careful of in children with chronic illness, and that is something called oral aversion. Who's heard of oral aversion? Yeah. All right. Whose child has had oral aversion? Yeah. Whose child still has oral aversion? Yeah. Oral aversion is really hard. Oral aversion in kids who are chronically ill is really hard to avoid and really hard to overcome once it's there. So, as you all know much better than I, even though I work in a hospital every day, you guys live with a child who has had a lot of stuff done to them, right? We've had intubation tubes, we've had nasal cannula, we have nasogastric tubes, sometimes even tracheostomies, we've had lots of surgeries, and etc. Lots of not so fun experiences happening around our mouth and our face, right? And now somebody's coming at me with a spoon full of yummy puree, and it's just not, it's very difficult when you've had all these negative experiences to suddenly make eating fun and a positive experience. And that is like, our whole approach is very much about the whole patient, and we call it child-driven. So our feeding approach, which is interdisciplinary, we have OT, SLP, nutrition, GI, all working together. Because we know if the child isn't enjoying that experience, they're not going to progress. So we need to make sure the tummy feels good, we're breathing comfortably, etc., etc. And then we start very slowly. We say, okay, if you don't freak out when I take this jar of puree and put it on your tray, we've had a good day. If you don't freak out when I take a spoon and I dip it in that puree and I smush it around on your tray, we've had a good day. If you get your fingers dirty and you don't freak out, that's a good day. And we slowly move up the hierarchy until maybe we're tasting it off our fingers, and that's a good day. But the whole thing is based around your child's response to the stimuli and making sure that it remains positive. Because the relationship with food, the relationship with families, the thing that we lose with eating problems is that social bonding that happens when we eat together. And eating together is such a powerful thing. And there are ways, even when we can only eat a small amount, or we only eat a certain type of food, or we only eat certain textures of food, there's still a way for that to be enjoyable and to have social bonding with our kids and to be able to enjoy the act of eating. And that's kind of what I want us to focus on. You guys know all this stuff. We don't really have to talk about it. It's scary when you can't eat, and it's scary when you can't swallow. So, you know, our risks are high. A lot of kids end up needing supports like G-tubes, or temporary supports like NG tubes to get through hospitalizations, right? And then, you know, so for our practice, if I have a child who I know is at high risk for oral aversion and they come in and they're really sick and they don't want to eat, I'm at a very low threshold to say, we need a bridge until they're feeling better. So we're going to do a nasogastric tube, even though that's a little aversive. It's less aversive than me trying to get the bottle into their mouth every 3 hours because they're not feeling well and they're sick. We're trying to get them to eat enough. That's stressful. It's stressful for you, it's stressful for them, and it prolongs the hospitalization. So let's bridge them through, let's not put any pressure on this, and as soon as they're well enough again, then we start working on food. Because this is the kind of stuff that can keep a kid in the hospital for a long time. So, at our hospital, we're very lucky that in the inpatient setting, all of us can go and see the patient at the bedside together, which is very exciting. And in the outpatient setting, we also see the patients together. So we have something called a feeding team. And families and their children will come and present to us, and we all sit around a table at the same time. And we'll watch your child eat or refuse to eat. And then problem solve with you about why that might be happening and give you recommendations on things you can do to help better. So, as we said before, it's really important to rule out aspiration and a swallowing problem first. This is a swallow study. I think you've all experienced, or at least most of you have experienced this before. So that's a nice normal swallow. It's an 11-year-old boy. And you can see that everything's going down the right pipe, which is here in between the spine and the trachea, and none of it's coming forward into his airway. Very important. How many of your kids have had to be on thickeners?
My daughter was for a little bit when she was younger.
Has she weaned off?
Yeah, it was when she was
Little
like 1 or 2 years old.
Okay. And I saw some other hands as well. So thickening is one of the things we can do if a child is shown to be aspirating for any reason in particular, whether it's neurological or anatomical. Slows things down, makes it easier to swallow, right? We can also change, anybody have to feed their baby inside lying position? Does that sound familiar to anyone? Common with a lot of preemies. Or change the bottle. How many bottles are there at Target, by the way? Whoa. There's so many bottles, it's really overwhelming. But there's specialty bottles too, right, that can help as well. So we have normal bottles, but we also have bottles that make it less work for the infant to feed. And then we can also think about things like adaptive feeding devices. So I think, let's see if it's in a couple of slides or not, no. Okay. So I do want to take a quick second to talk about my one experience in the ICU world with an active tube patient, where feeding really came into play. So I think for the most part, in the inpatient setting, I'm really not looking to push skills, I'm looking to maintain skills. We're not looking at advancing because I want a child to be well enough for it to be a positive experience, right? But sometimes a child is going to have a very prolonged admission, weeks or even months. And in that case, our medical bubble, which is the most important bubble, right? They have to be alive, they have to be physiologically well. There's also that next bubble, that development bubble that's happening while they're in the midst of this hospitalization. They're growing up in the hospital. And when that's the case, that's when we have to start saying, how do I help normalize this child's experience a little bit so that they can have some of those developmental milestones? They're really important, both for the experience socially and also for the rest of their life, because they're not going to be in the hospital for their whole life, that it's going to be months. So in this particular case, we worked with a child who had not eaten anything by mouth, who was on a ventilator, and we tried. It was important to the family. It was identified as a goal that we be able to celebrate a birthday with cake. I see we're big about cakes here, by the way. I'm very team cake. But no, but truly though, like the cake was a very important goal for the family. And so we worked with physical therapy and occupational therapy and myself. We Now, I know Dr. Carroll spoke yesterday about how tricky and scary it is to transport children on ventilators who are very sensitive to changes. We had the PICU fellow come down with us to radiology. It was a whole team effort to make sure that while we were also protecting his health and his medical issues, that we could also work on some of his developmental goals. And so all together as a team, we were able to slowly introduce PO in a way, or oral feeding in a way that was, pleasurable as it could be, as happy of an experience as it could be, and as safe of an experience as it could be. And the PT did the same thing with their physical therapy goals, and occupational therapy did with their occupational therapy goals. So it's very important to us in the inpatient setting that while we're going to be respecting that big medical bubble, that we also pay really close attention to that developmental bubble too. All right. So let's start talking about strategies. Let's go to the family with very, very limited textures. So have you worked with a feeding therapist yet?
We have a PT come to the house every other week,
Mhm.
and the last
month, we took the month of May off because of this. So about 3-4 weeks ago, she came and she brought a speech therapist because I was getting concerned. My daughter turned 1 in April and she refuses to feed herself. We've called this negative oral aversion for months. And she would hold her bottle, she wouldn't feed herself. She had severe reflux at the beginning. So, she gave me a few tips, tricks, that kind of thing, and 48 hours later, she started feeding herself and just took off. I didn't do any of these tips, tricks, it was just that I can't take credit for that, it would just happen to be that she started doing that. But she just loves the dry foods. I mean, even if you try, I was telling someone today, like, she doesn't like fruits, because they all have some sort of,
Juicy, wet
juicy,
element
wet
to them.
texture, yeah.
Okay.
Crackers, puffs, Cheerios, those are all great, and she's really done a really good job as far as feeding herself now. We've moved on to a banana, which was a huge step. But, and the other thing too is she refuses to even think about anything other than her bottle.
Interesting.
I put a sippy cup on her tray, and they've been telling me that for months, every meal, tosses it across the room.
So I have some thoughts for you about that.
Okay, go for it.
So, tongue movement for bottle is, again, we were talking before, pretty simplified, right? Just anterior, posterior movement of the tongue, a little bit of cupping. Movement for puffs, starting maybe to lateralize a little bit, but the cool thing about puffs and dissolvable solids is that they're gonna dissolve in your mouth if you leave them there for long enough, right? So she's not necessarily advancing her skills for chewing with a dry puff or a dry cracker or something that's dissolvable. I wonder a little bit if you started working on tongue lateralization more pointedly, if that would help her with accepting things that are a little more out of control in terms of liquids. So the bottle is super controlled, and the sippy cup, less controlled. Oh my gosh, something's coming into my mouth. I'm not controlling it as well. It's like, very free form. And I wonder if that might help a little. So one of my favorite go-to therapy objects / foods are veggie straws. Anybody know veggie straws?
And she did recommend that to me as well. I hadn't tried those yet though because it was such a big deal that she even, like I said, 2 weeks ago, just started
Very
feeding
exciting.
herself.
Yeah, and that's fantastic. So one of my thoughts with this is, so the reason I like veggie straws besides a puff, outside of a puff, is it's still dissolvable, right? Not scary, not choking hazard. However, your kid can hold on to it, right? And hold on to it while it's still in their mouth. And you can use their hand to push it over to the side of their mouth, right? Or model for her. If she doesn't like you touching her hand now because she's like, I'm feeding myself. I've learned this trick, Mom. You don't get to do this anymore. Then model. Oh, I'm gonna take my big dinosaur bite. Crunch, crunch, crunch. You should see us feeding therapists when we work with kids. It's kind of hilarious. We all say the same thing. Oh, look at you, crunch, crunch, crunch. It's in chorus. But modeling, bringing it over to the side and crunching with your molars. Because once the side of the tongue is touched with that food, the tongue is gonna go over there reflexively. It's actually a reflex, the lateral tongue reflex. So if you can stimulate that side of their tongue, it'll move it over automatically and they'll start learning, oh, I need to use my tongue to move food over to the side of my mouth to chew and then bring it back in. My other thought for you is food chaining. So food chaining is like particularly helpful for kids who are really rigid in what they will accept. And what we're gonna do with food chaining is we're going to take the preferred food, say it's a potato chip. I like this one a lot. Say it's a potato chip. It's white, it's crunchy, it's flat. And we're going to take a food that is similar to it in all ways except for one. And in this case, it's going to be the banana chip because it has a different flavor, right? Still crunchy, still flat and round, still yellow, right? Yellowy white, but has a different flavor. And then we're going to use that to progress to not just sliced banana, but frozen sliced banana. So now we're trying to match that texture or make the texture transition a little bit easier, right? In your case, maybe freeze-dried fruit would be a helpful step in between. So freeze-dried raspberries, freeze-dried strawberries are available at Trader Joe's and are really great for food chaining because we could take a freeze-dried strawberry, then we could leave a freeze-dried strawberry out for a little bit so it gets just the air on it, so it gets just a tiny bit like softer. And then maybe you start to move towards rehydrating that strawberry and then eventually to a strawberry. But doing it in these small incremental steps and recognizing that you may have to do this up to 20 times. That it's like, it is a process. And even children, even typically developing children who have no feeding issues whatsoever, sometimes take up to 20 times to accept new food. So if they refuse it the first time, don't give up. That would be my one thought for you.
Thank you.
Welcome.
One thing she does do, we've had trouble with, and I believe it with the 20 times, because she very easily gets frustrated, and if you cross, her threshold is very small, and if you cross that, anything, including the pus on her tray, she throws this fit and will not stop until every piece of food is on the floor.
And I'm all done.
Yes, like I'm all done, and it's not, I mean, the smallest thing, even try to help her with the blueberry milk, or like you were saying with the straw. I could see though after some time that she would trust you, that if I did it, that she would do it, but she doesn't let anyone help her.
So this is the thing though, right? Child driven, excellent. Like you're like, she doesn't like it when I help her, so I'll show her instead, right? That takes the threat away from it, and she still maintains her independence. So
Perfect. Thank you.
Awesome. All right, so we had some other folks who said they were kind of stuck in food jags or stuck on particular types of consistencies or working on chewing skills. Anybody else want to ask a specific question?
I have a question.
My daughter, she doesn't do it as much anymore, but for a long time she would eat petroleum jelly, like Vaseline. We had to hide it. She would eat it in the bathroom, and then she would, it was like candy or something, like we would go in and there'd be like a big dip out of it, and we'd be like, okay, that's weird, and then all of a sudden the whole jar would be gone. So we figured it out, so we would put it away, but is that, and she likes rubber, like today or yesterday she was chewing on the balloon. They were made an animal, and she took it, she was chewing on it, or we can't keep pencils with razors on them, she takes them off, so, and she likes the metal. She's a metal,
Sounds
so.
like she's very sensory seeking. Like she really likes to have stimulation to her mouth. And we actually see that in a wide range of children. Again, a sensory profile is different for each child. We go from the hypersensitive side to the hyposensitive side. And an occupational therapist could actually talk to you much more definitively about this, but from working with OTs, my understanding is children who are constantly putting things in their mouth and constantly kind of sensing that, seeking that sensory input, that's one side of the sensory spectrum. Is she able to take anything right now?
She is, yeah. We've had a small study. She's totally fine.
What about like really spicy or really flavorful foods?
She likes strong flavors.
Yeah.
She definitely likes
It's
some.
weird.
And weird flavors.
She combines weird combinations.
Sounds to me like she's kind of more on the hyposensitive side and
So.
really likes that stimulation, right?
Yeah, she packs food in her cheeks.
Yep, yeah, so very much so. I think that flavors are a great thing. And if you're looking for substitutions, there's quite a lot of things that we've used for chewing skills in younger children that are made to withstand chewing, like chewy tubes. They might be a nice substitution for a pencil or a
We tried
balloon.
that.
No, no good?
Yeah.
Okay.
Minutes, yeah.
No bueno.
For a minute.
Break it.
For a hot second.
Yeah, she wants to bring it. It's like a puppy dog, plastic. Like you get them all these toys, but then they want to eat your shoe or your handle to your room or something like that.
I would actually, if you have someone available and you talk with an occupational therapist, they might have some really nice sensory supports, like, I don't know what else they might recommend, like a weighted blanket, some brushing, etc., to help with the sensory, like calm the whole sensory system down, so that she's not seeking as much. That would be my suggestion, just find a occupational therapist.
Thank you.
You're welcome.
Ours isn't more about sensory, it's about choking. She chokes on everything.
Mm-hmm.
Well, she'll cough it because she's kind of coughing up.
Okay.
We haven't gotten to that, to lot of all this because she'll take 2 bites, she'll choke, and she'll want to eat it.
And then she'll be done. Mm-hmm. And I remember you saying yesterday that you had a swallow study, right?
We did.
Yeah, okay. With the mouth and throat, not just the esophagus.
Well,
I know she did the swallow study, they did the whole x-ray and the video thing, and they said that everything was fine as far as the swallow study.
No aspiration.
No aspiration. But then with the speech therapist, it's, even when she's in the hospital, we did the tongue
Yep.
laterally, and she was okay with that as well.
Okay. And, solids, liquids, both? Both. Okay. I mean, I think one of the things that I would be thinking about, there are a couple of things. So I noticed that your daughter is in an adaptive chair, which is great. And the adaptive chair is gonna go a long way in starting to support feeding skills because her trunk and her head will be well supported, right? Is she able to feed herself or is she dependent for food? She's able to feed herself.
she can feed herself.
Okay, that's great.
Relax. But she'll stop eating when she gets tired of feeding herself, and then we have to finish. We need to feed her if we want her to eat the whole thing.
How does that go?
What do you mean?
Meaning, does she refuse? Does she fight you, or does she?
Oh, no, she'll take it.
She'll take. Okay, she just gets tired.
Yeah.
Okay, gotcha. And does the choking happen at the beginning of the meal, in the middle, or at the end,
It's
or
very random.
very random?
It's very random.
I think that one of the other things I think about for all of your children in general is this esophageal piece, right? Because we have the smooth muscle in the esophagus, and so you can get backed up. Consistencies of food, so harder foods, foods that require chewing, may not be chewed enough and may start to kind of get hung up in the esophagus, and therefore there's something called referred sensation, meaning it's happening in my esophagus, but I feel like it's happening up here, and so it makes me cough. And the other thing you can maybe think about, so I would think about consistencies, about what you're asking her to chew. Maybe starting with the most calorically dense and challenging foods and ending the meal with the easiest foods. But I would also think about maybe alternating liquids and solids. Have you guys tried that yet?
No.
Alternating liquids and solids to help use the liquids to wash down any residue in the throat, mouth, and esophagus.
Okay.
And as upright as she can be during meals so that gravity can help with the assistance of breathing. I'm happy to talk with you guys more afterwards as well if you'd like, okay? Any other thoughts before I wrap up and hand it off to our last speaker?
I had just one thing,
Yeah.
as far as the threshold on when your child decides enough's enough in terms of feeding and to maybe feed some fathers. My threshold is very low, it's very easy to cross through. When she's done and says enough's enough, starts her immediately, because I tend to just give her the bottle and say enough's enough. But if it's at the beginning of the feeding where she decides that I'm done, do I give it some time, wait, try to work on my patience, or do I just go ahead and just say, yeah, I'll give her the bottle and then I'll try to get it next week?
I think that's a really good question. I think I get that one a lot. I think, it's gonna depend partially on your child and what strategies you have found help her to soothe and help her to calm down. If you know that once she crosses a certain line, you're just not gonna get anywhere, then that's when you just stop.
That's her.
Yeah. I would think a little bit also about maybe a no thank you cup for her or a no thank you bowl. We don't throw things off the tray, we put them in the no thank you cup. Oh, no thank you. Oh, no thank you. That's where it goes. It goes in the no thank you cup. So that's another strategy I might think about with her. And I think with her, this sensory hierarchy might be really helpful with her as well. So chewing and swallowing is the very top of the hierarchy. That's the hardest thing we're asking them to do. If we start way lower than that, where the child can have success and not be distressed, and slowly work our way up the hierarchy, so starting with tolerating it on our tray, then getting to touching it with our hands, maybe even just like, if we're talking about, so are we talking about sippy cups and instead of bottle, or just food in general?
Yeah.
He's talking about food in general. I was referring to, like, I even do the transitional ones where it still
Mhm.
feels like a nipple, but
Yep.
she, yeah,
What if we put food on her tray while she's drinking her bottle? You know, and just be like, oh, look, I'm tolerating the food being here next to me while I'm eating my bottle. This is cool, we're cool, it's all cool, it's cool. Or, you know, first Cheerio, then bottle. Okay, now I've got my bottle, this is cool, it's cool. You know, I would think about how you can back up on this hierarchy and try and get her to tolerate a little bit more on the lower end before asking her to get to this higher end where you want her to not be using the bottle and eating everything by mouth. It's a little bit of a process, but if you work within her tolerance zone, you might have a little more success. Just a thought. And this might actually also be really helpful for you guys. Creating a mealtime routine so that children know what to expect. I'm gonna be in my chair for half an hour and that's it, right? Like, I'm going to set up my meal chair, I'm gonna get into my high chair, I'm gonna sit with mom and dad for however long. You can start with 10 minutes. We're spending 10 minutes in the chair. And then we're all done. Cleanup time, it's cleanup time, let's wash our hands and put it away, right? That's okay. We go through the routine each time, so we start setting up expectations, and that really helps kids who are very rigid. If they know that they can expect, okay, I only have to go through this for 10 minutes, and then I get to clean up. Like, that can help them for those 10 minutes to kind of settle in and lean into whatever activity you're asking them to do. All right. Cool. Thank you guys. Any other questions before I pass on the baton? I'm happy to talk with anybody who has anything more specific that you don't want to necessarily raise their hand.